Welcome everybody, and I'm very grateful to have this opportunity to spend 30 or 40 minutes or so taking you through some ideas around how you might accelerate the impact of your research so that you can maximize the usefulness of research evidence. We start at the beginning though. We've got to think, why do we do research? What is the point behind all of this research that we're doing? The research that we're doing as part of Involve FP, but the research that many of us are involved in, many of us are still doing, many of us have done in the past, and hopefully many of you have engaged in, and many of you may be planning and hoping to do your own research into the future. So why do we do it? We want to identify and resolve uncertainties. If we're certain about something, then we really shouldn't be doing research to just prove our certainty. We're trying to identify the key uncertainties and then do the research that will resolve them. Then why do we need good and useful research? Well, we want to improve healthcare and we want to improve the outcomes. I'm not a practitioner. Those of you who are practitioners, you have patients that you are caring for. Those of you who are educators, you have people you are trying to teach. Those of you who are involved in social care, you have clients that you're trying to help. We want to make sure that health and social care and the outcomes of the populations we're looking after are as good as possible. So then we've got to think, how do we do good and useful research? And I'm going to take you through 5 aspects of what I would regard as good and useful research. And I'm going to try and illustrate those aspects with some examples from the literature and some projects that I've been proud to have been involved in. So what we're going to do, we're going to think about choose the right question, make the best use of what has gone before, choose an appropriate study design, keep it simple, and collaborate. So let's begin. Choose the right question. So sadly, this is an example of where things did not go well for the original researchers. And there's a little bit of a clue in the title of the article from the Medical Journal of Australia at the turn of this century, 20 years ago. Do doctors know best? Comments on a failed trial. So what were they trying to do? They were looking at treatments for patients with mild to moderate depression in primary care. And they wanted to compare 2 quite different approaches. Structured problem solving, so giving people crosswords or puzzles and getting them to try and solve those problems, or standard antidepressant drugs, so-called SSRIs, selective serotonin reuptake inhibitors. They worked out that to do this trial appropriately, they would need into the hundreds of patients. They actually identified 114 patients before they gave up. Because of those 114 patients, we've got to think, well, how many did they actually recruit? And the sad answer is no one. They didn't recruit any patients. Why? Well, I'm going to present that they chose the wrong question. They wanted to compare these 2 different approaches, 2 quite different approaches in people with mild or moderate depression in primary care, in the settings that they were working in. So what happened to the 114 patients? And what you're going to see is accumulating numbers of reasons why people were not recruited to the study. The numbers won't add up to the 114 because sometimes people have more than one reason, but it's important for us to think about this, because this may reveal that even if you change one piece of your design, even if you modify one piece of your question, you still might not have the right question. So 13 of the patients, 13 of the 114 were too depressed. 27 weren't depressed enough. So we've got these 40 patients already that were falling outside the boundaries of eligibility for the mild to moderate depression that the researchers were hoping to study. Some of them had a previous episode of psychiatric illness, serious suicidal intent, current drug or alcohol abuse, and fairly common exclusion characteristics for trials in mild moderate depression. And we would expect that to happen. We would expect some of the people that we identify to simply not be eligible because of important exclusion criteria. But also then what they said, well, if you're currently receiving drug treatment for your depression, you're not eligible. Because if you join the trial and you were randomised to the structured problem solving, then we'd need to stop that drug treatment. And 38 of the people that they identified were not suitable for the trial for that reason. And conversely, the counter argument is if they're currently receiving psychological treatment, such as the structured problem solving, then they weren't eligible either, because if they'd been randomised to the SSRI, then they'd have had to stop their psychological treatment. And there were 34 of those. Then, again, common reasons for in drug trials. If you're not able to tolerate the medicine, then clearly we're not wanting to recruit you to our study. So one of them had physical problems that precluded the use of an SSRI, and 5 had previously tried an SSRI and hadn't responded to it. Then we had the recruiters, the general practitioners, the people working in primary care. Did they agree with the research question for their patients? Did they agree that they were willing to have their patients join the trial? Well, the GP wasn't confident about using problem solving for 20 of the 114 patients. And then there's a whole string of other reasons why people were not eligible, and 22 other failures. Now, as I said, you can't add these numbers up to work out the 114 because some people had multiple reasons. They did, however, have 7 left. From the 114, they had 7 left. But when they offered the trial to those 7 people, all of them declined. So you can see that it's a reasonable enough research question, but it wasn't the right question for this population of patients in this setting of care for these practitioners. No one of the 114 was recruited to the trial. So one of the ways you might go about choosing the right question is to have a good look at what's gone before. And in the Involve FP, it's one of the things we're doing. We're doing a review of the existing research, and maybe the answer is already out there. Or maybe that review of the existing research will show us what the new study really should look like. So I'm going to illustrate this with an example, again, of how the research was reviewed and how it is going to be having an impact, because it's going to inform, well, it has informed a guideline. So what's the example? The example is a set of guidelines that were published by the World Health Organization towards the end of 2018, and they related to housing and health. How could you improve housing in order to improve health? The guidelines, as I said, are published towards the end of 2018, available on the WHO website. And they were based on a series of systematic reviews that provided the evidence base that could lead to the recommendations in the guidelines for these main areas. Inadequate living space, or crowding. What would need doing about crowding to try and improve health? And would it improve health? What is the evidence for crowding leading to ill health? Low and high indoor temperatures. What can be done about them, and what are the health consequences of them? Injury hazards at the home. How to determine how many injury hazards there may be and what to do about them. And then accessibility of housing for people with functional impairments. So those were the areas that were tackled in the systematic reviews to inform the recommendations in the guidelines. And I'm just going to focus on the first one, just to illustrate again how you can maximise the impact, how you can accelerate the impact by doing good research. So it's a systematic review. All of the systematic reviews for all of those topic areas are published alongside the guideline. And Web Appendix A, as it's called, is the one to do with housing and crowding. And what went into the review? Well, 3,181 records were checked from a search of a variety of databases. 105 eligible studies were identified, so it's a pretty big review. The median size of Cochrane Review, which so many of you I'm sure have heard of, Cochrane Reviews focus on the effects of healthcare interventions. The median size of a Cochrane Review is 7 included studies. So this is a big review. 105 eligible studies identified, and of those 105, 102 had enough data reported to be used fully in the review. And so the data was extracted and it was grouped on the base of health problems. So tuberculosis, there were 23 studies. There were 54 studies of other infectious diseases, 11 studies of gastrointestinal and diarrheal diseases, 13 on mental health, which included stress, and 3 to do with sleep disorders. So you can see we're compiling the evidence that already exists. We're making use of what has gone before. And then just to emphasize the strength of the review and the quality of the review, for all of those studies, all of those 102 studies in the review that fed the guidelines on crowding, data was extracted. And there are tables and tables and tables like this in that web annex. So data is extracted to describe each of the studies, to provide a summary of each of the studies. The risk of bias in the studies, and these studies range from cohort studies, case control studies, cross-sectional studies, ecological studies, some randomized trials for some of the questions. Risk of bias across a variety of domains was assessed, and then a traffic light system being used. Green means there's low risk of bias. Red, high risk of bias. Yellow, it's unclear. And some of them, as you can see on the picture, were not applicable because of the study design. And then grade evidence profile tables were prepared. And grade is a way of looking at the evidence to, in a transparent way, show the strength of that evidence, to show something, summarize something around the risk of bias, inconsistencies in the evidence across the different studies, whether or not the evidence directly relates to what you're interested in, and whether or not it's imprecise. And then notes fields, and you can look at the annex, look at how this review was presented in that web annex for that guideline, and you can see transparently the strength of the evidence. And what did that evidence do when it was presented to the guideline development group who were responsible for writing the guideline? Well, it allowed them to conclude that the certainty of the evidence that reducing crowding would reduce TB, so I'm just focusing on the tuberculosis element, was assessed as high. And that led to a WHO strong recommendation. It's the top one on the picture that you can see now. The crowding recommendation. Strategies should be developed and implemented to prevent and reduce household crowding. Strong recommendation, which is the highest level of recommendation in the guidelines. And you can see some of the other topic areas there as well. But the point being that use of what was existing in a transparent, high quality way allowed the WHO to issue guidelines to all of the member states around these things to do with housing, and to be transparent about the strength of the evidence and the source of the evidence that was being used. So let's move on to make sure you choose an appropriate study design. And as I've said in the housing guidelines, the systematic reviews covers a whole range of study designs because you need the correct study design for the question that you are trying to answer. So get the right question, find what's already out there, and then choose for the new study the correct design. And I'm going to give you a couple of examples now, and these are examples that come from randomized trials, which is the type of research that I'm most involved in. And again, think, why do we do them? Well, we're all consumers, providers, payers, carers in health and social care. We hope that what we take, what we're given, what we'll give will do more good than harm. Whether we're practitioners or we're just in the chemist trying to buy something for ourselves or for our families, a mild analgesic, a new type of toothpaste, a cream to stop us from being overexposed to the sun. We need reliable, robust, trustworthy information from the past to help us make good choices about the present and the future. And we need research that will predict what's likely to happen if I use or I don't use this intervention in the future. So that's why we're doing trials. We're doing trials to generate comparison groups that only differ because of the random allocation to receive in a typical easiest study, to receive the treatment or to receive usual care. So that's why we do randomized trials. And the idea is not new. I can go back to the 17th century, and Van Helmont issued this challenge. Let us take out of the hospitals or the camps or from elsewhere 200 or 500 poor people that have fevers, pleurisy, etc. Let us divide them in halves. Let us cast lots that one half of them may fall to my share and the others to yours. I'll cure them without bloodletting and sensible evacuation. But do you do as ye know? He's suggesting a randomised trial. He's suggesting, I don't think that we need to use bloodletting. I'll treat a randomly chosen half of the group without it. You do as you want for the other group, and then we'll compare and we will see whose group does better. And that leads us to then, okay, we want randomised trials, but we also want to keep it simple. If you want to maximise the impact of your research, if you want to make it useful, keep it simple. It will allow you to do better research, bigger research, faster research, and it should help people see clarity in the findings. So here's an example, and it's not really a medical example. We could regard this as maybe it's a public health example, but it looked at whether or not people who were picking tea in India would benefit from being given glasses to correct refractive error if they needed the glasses. Would it benefit them? Would it help them to pick more tea? Would it improve their visual quality of life? And the trial's called the PROSPER trial, Productivity Study of Presbyopia Elimination in Rural Dwellers. Presbyopia, I struggle to say it, is almost universal decline in our eyesight as we get older. Globally, 1 billion people have it. But there'd been no randomised trials of using interventions to try and improve it, such as giving people glasses, would help improve work productivity, would help improve how they do their jobs. And so the trial was on a tea plantation in Assam, India, recruited tea workers aged over 40 years and randomised them to either receive free glasses to correct refractive error immediately or to receive the free glasses after the 11-week evaluation period. And it recruited 741 workers. Kept it simple. The main study outcomes were just two things. One was how much tea do they pick in the baseline period before the trial began and then during the evaluation period, and what was their visual quality of life. And so the first of those is routine data. It's what they would be routinely collecting. When the person had finished the shift for the day, they would bring the tea and it would be weighed. So that was in the system. The visual quality of life was a simple questionnaire which asked people how they felt about the quality of life in relation to their vision. What did it find? Well, it was published in The Lancet a couple of years ago, and it found a significantly higher increase in the mean productivity in the intervention group. The group that were given glasses immediately to correct their refractive error to improve their vision, on average, picked more than 5 extra kilograms of tea per day, a 22% increase because they were wearing the glasses. And this increase was even greater among people over the age of 50. It exceeded 7 kilograms per day for them, which was nearly a 1/3 increase. And they also found significantly higher visual quality of life for the people that were given glasses immediately. How would you summarise that? Well, keep it simple. Article in The Economist, Wear Glasses Earn More. That was its title, feeding off the PROSPER trial. It also informed part of the Lancet Global Eye Health Commission's report, which came out earlier this year. And one of the statements in that report is very simply addressing avoidable vision impairment and enabling people with permanent impairment to access and function well in the workplace increases productivity. And that is because of the PROSPER trial. So the last of the 5 things I'm going to speak to you about is collaborate. We want to make sure we've got the right question. Well, if we collaborate, we will hopefully reach consensus on what the right question is. We want to make best use of what's gone before. If we collaborate, we're probably going to be able to draw on the knowledge of the other people that we're collaborating with on what has gone before. We need to choose the right study design. And again, let's collaborate. Let's reach consensus on the correct study design, and then let's keep it simple. And again, collaboration is probably going to help you keep it simple. Hopefully it's not going to go the other way and mean that everybody wants a little piece of the question. Everybody wants to put their favourite outcome in. No, we should collaborate. And maybe we can use something that I'm not talking about today, something called a core outcome set, where practitioners, researchers, patients and the public have come together in advance to agree on the set of outcomes that should be measured in all research in that topic area. Build on that collaboration. Use a core outcome set if one exists. But I'm going to show you an example just to finish of probably the trial that I'm most proud of my involvement in throughout the time that I've been a researcher. It's a trial called the ISAT trial. And it's a trial that tests the treatment of a condition called a subarachnoid bleeding. And to put it simply, some of you will know what this is already, but for those of you who don't, imagine the blood vessels on the surface of the brain. They may have a weak spot. It's called an aneurysm. And that may burst. And the blood loss will be tiny amounts. And so it may clot and get a scab. But the problem is it could burst again. And so we need to treat it. So what we have to think about for treating it is how are we going to get to that weak spot? We can't clamp the blood vessel itself because that's the blood vessel feeding the brain. So we've got this weak spot, this bulge. Well, we could clip it, and that was the classical way of treating it. So that means going in from the outside, lifting the skull, going down to the ruptured blood vessel and putting clips on to that weak spot. So the blood vessel is still working, the blood is still going through it, but we've clamped the weak spot. The other way is to go in through the blood vessels, feed a coil into the weak spot from inside and block it that way. So there are two different ways of managing it. And you can imagine that there's a burst pipe under the road. Well, are you going to dig down to it to fix it that way? Or would it be less disruptive to go from the inside and try and patch it from the inside? And basically that's what's being done. And so the question was, what's the best way to stop it from bleeding again? Leading to the International Subarachnoid Hemorrhage Trial, ISAT for short, which compared the two approaches. Endovascular coiling, going in through the blood vessels to put coils in the weak spot to seal it up. Neurosurgical clipping, neurosurgeons going in from the outside to get to the weak spot and put a clip on it. 2,143 patients joined the trial. 1,073 had endovascular coiling. 1,070 had neurosurgical clipping. And the key thing is, it's a randomized trial. People were randomly allocated to receive the coiling as the preferred option or the clipping. And in terms of collaboration, what you have to remember now is that these were two different approaches to managing this condition. The clipping is done by the neurosurgeons. The coiling is done by the neuroradiologists. Two different disciplines. And if you think about medical practitioners, medical disciplines, who might be regarded as very confident about what they do, I'll leave it to you to decide how challenging it may have been to have neurosurgeons hand over their patients to the neuroradiologists, but they agreed to do so. And this was a trial led by two, what I would call jobbing clinicians in Oxford, Andy Molyneux, a neuroradiologist, and Richard Kerr, a neurosurgeon. And they agreed that this was the question that needed answering, and colleagues around the world, colleagues in dozens of centres around the world agreed, and so did the patients that they approached for the trial. What happened? Well, the trial itself took quite a while. The pilot trial began in 1994. In 1997, received funding from the Medical Research Council, and it went for another 5 years. But then things stopped very quickly. 29th of April 2002, the Data Monitoring Committee, the DMC, recommended that the trial should stop. The trial was closed completely on the 2nd of May. Follow-up continued of the patients, but no one else was randomised. And the first report was published in the Lancet on the 26th of October that year to get the message out there quickly, because what the Data Monitoring Committee had seen, what the Trial Steering Group agreed with, what the collaborators agreed with, was there was a clear benefit in favour of endovascular coiling. In patients with a ruptured intracranial aneurysm, for which endovascular coiling and neurosurgical clipping are therapeutic options, the outcomes in terms of survival free of disability at 1 year is significantly better with endovascular coiling. That's the report that came out just months after the study had closed. And a few years later, as more and more follow-up was gathered, then another report came out in 2005 from the collaborating team, and this included this graph which shows the number of people dying from randomization time zero over the next 7 years. And you can see that in those first few days there's very little difference between the two groups. But then in the subsequent weeks, the deaths are going up faster, they're going up more in the neurosurgery group, in the clipped group, than they are in the endovascular, the coiled group. Highly significant finding, highly important result for practice for this life-threatening condition. And another way of looking at it is looking at what was the primary outcome for the ISAT trial, which is the person dead or dependent on the care of others at 1 year after randomization. And what that revealed was that 31% had either died or were still dependent on the care of others at 12 months in the neurosurgery group, but it'd fallen to 24%. 7%, 7 people in 100 were not deceased or dependent on the care of the other because they were in the coiled group, not in the clipped group. So what's the impact of that? Has that trial made a difference? And one of the reasons I feel proud to have been involved in the trial is yes, it made a difference. It made a difference quite quickly. And this just takes a couple of pieces of literature, to show you how common coiling was over a period of time in different countries at different times before and after the ISAT trial. So in 1992, globally, no one was being coiled. And it's simple. Why that? Because the coils weren't available. They hadn't been invented. They hadn't been brought into use for this particular type of aneurysm treatment. Study done towards the end of the first decade of the century looked back at the USA in 2000 to 2002, found about 3% of people were being coiled then, and if you jump down a few lines, 2004 to 6, it'd gone up to 17%. And that's the period after the ISAT trial had come out. So we take the UK data, 2001, ISAT is still running in 2001. About a third of people with this condition in the UK were being coiled in this it's a single hospital study. Went up very slightly in 2002 and got up to 2/3 of the people by 2003 in that single hospital study from the UK. A bigger study from the UK looked at the year 2011, and that's a national confidential inquiry into deaths, and that found that 86% of presenting people with an aneurysm causing a subarachnoid hemorrhage, 86% of those people were coiled. In India, in the 2006-2011, that study found that 95% of the people were being coiled. The USA still was lagging behind, but by 2012-2014, in another study there, more than half were being coiled. And this is down to collaboration leading to the definitive trial, and the definitive trial leading to people making different decisions than they would otherwise have made about the care of the patients that they're looking after. What about guidelines? Well, in 2012, the American Heart Association and American Stroke Association issued joint guidelines in which they said for patients with ruptured aneurysms judged to be technically amenable to both endovascular coiling and neurosurgical clipping, endovascular coiling should be considered. That you should go down the coiling route. That should be the beginning plan. That should be the first thing you should be thinking of rather than clipping. And earlier this year, February 2021, NICE have issued guidance to the National Institute of Health and Care Excellence in the UK, which provides guidance for health and social care in the UK. Issued draft, a consultation document on the new guidance for subarachnoid hemorrhage. And what does it say in that draft guidance, which is issued for consultation in February of this year? If interventional treatment to secure the aneurysm is an option, offer endovascular coiling, preferred option, or neurosurgical clipping if endovascular coiling is not suitable. So again, collaboration on the right question. 2,143 patients agreeing to join the trial, agreeing to be randomized, agreeing for the equivalent of a flip of a coin to decide would they have coil or would they have clip to try and prevent that aneurysm from bleeding again. Change practice, change guidelines has led to recommendations such as this. So I've finished there, and just to reinforce the points, if you want to accelerate the impact of your research, if you want to maximise the usefulness of research evidence, choose the right question. Make the best use of what has gone before. Choose an appropriate study design. Keep it simple and collaborate. Thank you very much.